Thank you. Microphone on?
Please.
Okay.
The set is on you.
Excellent. Good evening. Thank you very much for the kind introduction. Thank you all for coming up and giving up your evening. I don't speak Spanish, but I speak very fast, so I'm going to slow down. I'm very grateful for you turning up, and I'm going to talk about really a new platform that we are developing, where we look at the whole group of parameters together rather than just individual parameters to improve the outcome of our patients. I'm going to start with the simplest of things. You all know pulse oximetry. You all know that it's probably the most important monitor that has come into anesthesia and critical care in the last 50 years. We saved so many lives with the pulse oximeter. But traditional pulse oximetry, as good as it was, it's not as good as what is available today. The difficulty is that the traditional pulse oximeter assumes everything that moves to be arterial, and we know that's not the case. So the SET technology that Joe Kiani and Mohammed Diab produced in 1995 uses special filters to remove all that, so it works in the people you need it most in. Small babies moving, elderly patients who are very sick with low perfusion, and last but not least, it doesn't depend on skin pigmentation. So it doesn't matter what color skin you have, it will read accurately. And that was a great advance. This is why SET technology is really in just about every neonatal intensive care unit in the world. It's used for congenital heart disease screening. It has stopped many children getting premature retinopathy because of high oxygen concentrations. So it really is the building block that Massimo was built on. Now, pulse oximetry does more than just give you a saturation. So the pulse oximeter that you get from SET technology gives you probably the most predictable sort of parameter that looks at patients when they're deteriorating, respiratory rate, which is also the most badly calculated one. You know, patients deteriorate. And so you can do that by looking at the respiration rate from the plethysmograph signal. We also have a couple of other parameters that are available on the same pulse oximeter. PVI, which is Pleth Variability Index, that looks at fluid responsiveness. Now, people talk about fluid status all the time. It really is very difficult to measure people's intravascular volume or total body volume. But what you can measure is fluid responsiveness. So if I give somebody a bolus of fluid, does that improve perfusion? Does that improve cardiac output? And that can be done using the PVI. And PVI has been used in a variety of situations, mostly through ERAS and goal-directed therapy. And you can see in this group of patients undergoing major abdominal surgery, those that had fluids administered using PVI had less fluids infused intraoperatively, they had better postoperative courses, and they had lower lactates, and they were discharged earlier. Again, it's a non-invasive parameter that you can have on the same pulse oximeter that you would use every day. That's not enough, okay? So instead of having enough wavelengths in a pulse oximeter to measure those parameters, we added a rainbow parameter. The rainbow parameters are more wavelengths going through the pulse oximeter to give you additional information. And probably the most two useful parameters that used widely is SpHb, which is continuous non-invasive hemoglobin. You don't have to do blood draws. It continuously measures the hemoglobin minute by minute, plus or minus 1 gram accuracy. The other couple is the carboxy monoxide. So basically, carboxyhemoglobin can be detected through the pulse oximeter, and many of the fire brigades in the US and Europe have now switched from having blood gas analyzers, co-oximeters in the ambulance, to using this to detecting carbon monoxide in patients who have been rescued from fires. The other one is methemoglobin. COVID has produced a lot of interest in giving nitric oxide, inhaled nitric oxide, which has the disadvantage of increasing methemoglobin. And again, we can detect that through the pulse oximeter without having to do any more than you're currently doing. But I think one of the most exciting parameters we do is something called the oxygen reserve index. How many of you have heard of the oxygen reserve index? 2 people, great. So Before I get to that, let me take you through the hemoglobin. This is a trended hemoglobin throughout an operative procedure. You can see the lab results versus the non-invasive hemoglobin, pretty accurate correlation. But you can see the SpHb trend when the hemoglobin is dropping, when it's rising, and when it's stable. And what that allows you to do when you combine it with the PVI, the fluid responsiveness, is to know whether the hemoglobin is dropping because the patient is bleeding or because the patient is getting hemodiluted. So if you're bleeding, you would drop your hemoglobin and you will be fluid responsive. If you're hemodiluting the patient because you're giving too much fluid, your hemoglobin will drop, but you will not be fluid responsive. And again, this is done non-invasively with the same parameters you have. And if you look at the published studies on outcomes using SpHb, orthopedics, general surgery, neurosurgery, facial surgery, cranial surgery, lots of papers coming out now. They show that the patients who have SpHb used have got a reduction in the number of patients transfused, the number of units that transfused less, decreased time to transfusion, you react quicker. Cost reduction is significant. And the most important is the reduction in 30 and 90-day mortality by about a third. And so many units around Europe, the US, are using non-invasive hemoglobin as part of the routine management. As you can see by the many guidelines now that are included as part of the process. The Society for Advanced Blood Management, European Guidelines on Management of Major Bleeding, CBA, all of these societies have included non-invasive hemoglobin as part of their process for managing blood during surgery. Now, ORI is a parameter that really was invented because the pulse oximeter is great, but pulse oximeter does not tell us when we give too much oxygen. When you give too much oxygen, you get hyperoxia. And hyperoxia is damaging. Because hypoxia is damaging because you get adrenergic response, you get tissue hypoxia and tissue damage. But hyperoxia causes vasoconstriction, it causes oxidative stress, it releases free radicals. And so the difficulty, even though we see here in the emergency department, in the intensive care unit, even after traumatic brain injury, hyperoxia is almost as bad as hypoxia when it comes to traumatic brain injury. The difficulty is we can't tell when the patient's hyperoxic. And the reason we can't tell is because, as you can see here from the Centre TBI data from Cambridge, the patients come in, they are on 100% oxygen as they transfer them into the intensive care units, they've got traumatic brain injury, they've got other injuries. The saturation we look at, 98, 99%, that's fine. The problem with a 98, 99 saturation is your PO2 could be 100 and it could be 400. Because the pulse oximeter is very good at detecting hypoxia, but it's not very good at detecting hyperoxia. And that's why the oxygen reserve index, which is unitless index from 0 to 1, measures that little bit of oxygen between 100 and 200 and gives you an index to show how the relationship is. So by looking at that index, you can tell and prevent hyperoxia. And it's very easy. It's part of many units now using it as a way of preventing hyperoxia. What also it gives you is gives you this oxygen reserve. So because the lungs are filled with oxygen, you have a bit of a warning. You can see here by using the pulse oximeter alone, the time you would get before hypoxia develops. And when you add ORI, you get an average of about 30 to 45 seconds more warning before the pulse oximeter starts to drop. So in difficult airways, neonates, changing tubes, apneic bronchoscopies, you can see how the alarm here, so this pointer is not brilliant, but you can see where the arrow is pointing, and it's the apneic ventilation starts. It takes time for the ORI parameter to drop, and then about 45 seconds later, the pulse oximeter starts ringing. So you have time to say, okay, I need to put them back on a ventilator, I need to face mask them, I need to get out, or I need to intubate. And that gives you the extra bit. And when you talk to engineers and average persons, they go, 45 seconds, is it really making that much difference? When you're a pediatric anesthetist trying to intubate a neonate, 45 seconds seems like eternity, you know, especially when that pulse oximeter is going beep, 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 beep. You know, so it's adds a lot. And the use is now, a lot of the airway societies are using it as part of the intubation protocol. Pre-oxygenation, what we do with pre-oxygenation is we put a mask on and we wait to whatever we think is a reasonable time, and then we get on with it. But in fact, actually with ORI, you can see when it plateaus, it means you can't get any more oxygen in, and you can just get on with it. And again, lots of people are now using high-flow nasal oxygen and ORI to make sure patients are pre-oxygenated appropriately. And even when you give elderly patients nasal cannula, 2-3 liters a minute, some of those patients with good lungs become hyperoxic. And there's no way you can tell because you generally measure the saturation. Now I want to move on to the brain, and I know many of you are experts in monitoring the brain, but I've spent 20 years looking after brains that have been injured, and as I get older, I'm getting a little bit worried, and I want to make sure my brain doesn't get injured. And so really, it always astonishes me that in intensive care, we have, and in anesthesia, we monitor everything: liver, heart, kidneys, skin, pressure sores. The one thing we don't really monitor regularly is the brain. The tide is turning, people are listening and beginning to be more interested in the brain. And there's this assumption that as long as we have normal hemodynamics, everything's okay. But we know that's not the case. We know it's far from being the case. And when I used to talk to some of my colleagues in general anesthesia and general intensive care, they used to say to me, it's the brain, nothing to do with me. That's neurosurgery, that's neurointensive care, it's your job. But in fact, actually, most of the patients that come into my neurointensive care have already had a brain injury. Okay? Most of the patients that go into general intensive care have not had a brain injury. Yet, the incidence of delirium approaches 70-80%. POCD is rampant. Strokes, seizures. So really, the time is to monitor the brains that are already normal rather than the brains that have already been injured. And if we look at our common practice, and you all know this, we're very good at measuring what we deliver. I give you half a Mac, that should be okay. I give you a TIVA, whether it's Schneider model or some other model that you like. But really, there is no way you can tell by using those at any stage throughout the procedure what is happening to the brain without looking at the brain. Because we don't really measure the anesthetic concentrations at the site of action. And we know hemodynamic parameters are not a good reflection of depth of sedation. And those of you who use SedLine know that patients sometimes have hypertension in the middle of the operation, and you look at the SedLine, it hasn't changed. Say they have pain as a result of an incision, you look at the SedLine, it hasn't changed. Sometimes a surgeon says, the patient's moving, and you look at the SedLine, it hasn't changed. But the temptation is to turn the dial up. Patient moves, turn the dial up. Surgeon complains, turn the dial up. After the third complaint, you don't listen to him the first time. And so the reality is we need to move away from that and come back to balanced anesthesia. And I was really pleased. We worked very hard with the Association of Anesthesists in the UK, which has also transformed the way people look at the brain. And they've moved away from just saying you only need to use brain function monitoring because of awareness. They're now talking about part of awareness, but also post-operative delirium, cognitive dysfunction, and improving recovery times. And they're moving away from just using a number. The number is okay in TIVA and muscle relaxers, but they're saying you need to have, come on guys, you're more than just robots. You know how to look at chest x-ray, but you're not chest physicians. You know how to look at an ECG. You're not cardiologists. You look at a CT scan. You're not neurosurgeons. So why not look at the processed EEG without being a neurologist? And so the push now has come back to say, we need to know a bit more than just a simple number, 20 to 40 or 25 to 50. We need to understand the DSA. We need to understand the different bands. And that would make life a lot easier, a lot better for our patients, not just the ones with TIVA and neuromuscular blockers, but those with TIVA and even with those inhalation anesthetics. And interestingly enough, everybody says Mac, half a Mac is enough. And even the ASA now, American Society of Anesthesiology, is saying, guys, minimum alveolar concentration is simply a population average of those who are going to move when given a surgical stimulus. It's not an indication of consciousness. It's not an indication of whether you're aware or not. And so we need to move away from it. And they are beginning to recommend now, again, that you really need to look at process EEG, DSA in particular, not just for awareness, but for reducing delirium and hypotension, for reducing the use of vasopressors, faster emergence, confirmation that you are giving that hypnotic drug, and for all types of patients, not just the ones over 70, not just the ones under 10, but really everybody who's having an anesthetic should have the brain monitor. Now, in intensive care, it's not as simple as anesthesia, because in intensive care, we think that we can assess the patient clinically, okay? And most of our ideas about managing patients in intensive care is make sure they are unaware, but calm and cooperative. And that is the basis of basically the RAS score. Most of us use some sort of score. Richmond agitation score in the ICU seems to be very well used. And we try and keep the patients in the all, drowsy, lightly sedated, responsive. You don't want them combative and jumping at the bed, which several of them try and do. And you don't want them completely unconscious and unresponsive, which even more of them do. And you can understand why that happens, because you're a night shift. You're one nurse looking after one patient, maybe two, okay? The patient is sick. They're intubated. They need the drains changing. They need the pressure source checking. They need suctioning. They need the chest x-ray. So you can't afford to have them too light and extubate themselves in the middle of the night. So the temptation is to jack up the sedation, okay? We always used to joke to say that the anesthesiologist would like their patients awake so they can go home. Intensivists would like their patients asleep so they can go home. Because that's the reality, okay? The last thing I want in intensive care is every patient trying to get out of bed, okay? So oversedation is a serious issue in intensive care. And when I talk to people like Alex Monet, Tabul, all the big gurus in intensive care, and I go, do you monitor your brains in patients? No. You've just spent the last half an hour talking to me about renal damage. Yes. But you don't think brains are important. Well, we monitor our patients clinically. How many patients in your intensive care are paralyzed or have bad enough lungs that can't be assessed clinically? Oh, about 30%. So in a unit of 60 patients, 20 patients every day can't be assessed clinically. So how do you assess those patients? We should be using brain function monitoring, is the answer I got back. So I think what brought it to home really is COVID. In COVID, we looked at the way we were sedating our own patients, and we looked at another intensive care unit in Italy. And we found that, not surprisingly, they were all over-sedated. Why? These people had a virus that could kill other people. They were in a side room. We were all wearing PPE. The nurses were covered up. We had to turn them every 4 to 6 hours, sometimes maybe every 8 hours. We didn't want them to get extubated. We didn't want to get disconnections. So the temptation was to over-sedate them. And when we looked at our own patients, 3/4 of our patients were over-sedated. And the incidence of delirium was almost 100%. And it's not surprising, because we didn't know how else to do it. And since that episode, every patient in my intensive care unit has got depth of sedation monitoring on. It wasn't easy. It wasn't straightforward. But now we've got a protocol, and people are following it. And our nurses and clinical fellows are driving it, not the consultants. And very pleased, after much negotiation and wrangling, the consensus on sedation in intensive care, and we have finally produced guidelines to say that it's recommended that all patients that are sedated in intensive care, whether they're paralyzed or non-paralyzed, that you cannot assess clinically, should have a depth of sedation monitor used. And there is an explosion in intensive cares now in the UK because they're reactive. When something happens, they react to it rather than being proactive. And in Europe and throughout the world, actually, to be honest with you, Australia and New Zealand are looking at sedation in intensive care as a measure of making life better for those patients you can't assess clinically. Now, you're all familiar with our beautiful Z-line monitor, and I'm not going to go through it in detail. I just want to show you that not all numbers are equal. Just like not all pulse oximeters are equal, not all numbers are equal. The PSI number is really worked through a fantastic algorithm that's taken a lot of effort and time to perfect it as much as possible as a reflection of the depth of sedation. Okay? Some people say spectral edge frequency sometimes is better, DSA is better. Yes, in certain situations, you may want to use those. But ultimately, the default should be the PSI. The PSI, we've done all the hard work for you. Some people want to do their own algorithms. That's fine. But to be honest with you, PSI has done all the work for you. And in intensive care, we tend to run the patients around 40 to 50 unless we need them deeply sedated. And in the operating theatre, it's more towards the 25. And they seem to work very well. There are two things that interfere with Z-line or anything that you use skin electrodes for. One is EMG activity. And if the EMG activity is high, which sometimes we use as an indication that the muscle relaxants are wearing off or the patient is in pain, then the signal will be affected. But again, we worked on the algorithm so we get rid of as much of the EMG activity as possible. But if you're shivering, if you're seizing, if you're moving, that will still be affected. The other one, which is as we get older, our brain power reduces. Okay? We try and kid ourselves by talking about replacing it with experience, but the reality is that's not the case. It doesn't compensate. But nevertheless, as we get older, the power reduces. And because all biological signals are a function of noise to signal ratio, because the brain power reduces, the noise around us, electrical noise, noise from ventilators, noise in the operating theatre, becomes more important. So elderly patients who are very heavily sedated can sometimes have a paradoxical number rise. So you might see the BIS number going up. You might even see the PSI number going up. And that's when you have to look at something more than just a number. But we worked hard on the PSI to make sure that we read throughout the spectrum, throughout the power spectrum, so we can get as much of that as possible. So it works very well in geriatric patients. But nevertheless, an elderly patient, very, very heavily sedated, you may get a paradoxical large number that you don't really believe, and the answer to that is not more anesthetic. The answer to that is looking at the rest of the spectrum and seeing what is going on. Now you get for OEG, PSI trended, and the DSA. And I think the DSA, apart from the fact that it's a very pretty color and you got seeds that are going to grow like a DSA, I think it's great visually to look at it from a distance and say, I know what's going on in that brain. And one thing that we want to avoid is burst suppression. Now, I'm sure you know what burst suppression is. That's when the brain is effectively stopping and starting. So when you're in suppression, the cells aren't communicating with each other. They're just staying alive. And when you're bursting, it means the cells are communicating with each other. And so deep anesthesia, very deep anesthesia, causes burst suppression. And burst suppression has really, in my opinion, no role to play in anesthesia or intensive care, except in two probably dubious, but I will allow them, situations. One, intractable seizures. The neurologists sometimes say, cannot control these seizures, we've tried everything, can you please put them into burst suppression? If you look at the evidence hard, the evidence is so-so. But what do you do with a 25-year-old who's got autoimmune encephalitis, who's seizing, you can't control any other way. So we play along and do that. And the second is intractable intracranial hypertension in a person where you've done everything possible. You've sedated them, you've cooled them, you've decompressed them. What else are you going to do? Again, the evidence is pretty small for that, but nevertheless, apart from that, there really is no indication for burst suppression anymore. Burst suppression is associated with delirium, increased length of stay, increased mortality, POCD, increased use of vasopressors. So really, there's nothing that says increased depth of sedation is good for you. Now, some people will argue with you that actually, burst suppression is not that bad, but there is no benefit to it. So why would you allow something that could be harmful, but has no benefit to take place when you can stop it? The beauty of the DSA as well is you have a drug signature. So you can see the drug signatures for propofol, inhalation anesthetics, ketamine, which many of us are beginning to use now, in sedation in intensive care and part of anesthesia, and dexmedetomidine. And what amazes me is that a lot of our colleagues in gastroenterology or do procedural sedation, they play along with, benzodiazepines and propofol infusions as if it doesn't matter. And when you look at it, really, what those brains and EEG should be looking like this one here, light sedation. But quite often, when you get called to the endoscopy suite to fish that patient out to stop breathing, they've given them such a high enough dose that they're completely unconscious and they're effectively anesthetized. And there's a paper in the US showing that almost 50% of patients undergoing procedural sedation are having general anesthesia, and 25% of them are going into burst suppression. And yet we send them home a couple of hours later. Dexmedetomidine, again, very, very standard signal, low dose, high dose, so you can judge how much you're giving. And there is no one size fits all. This idea that everybody needs the same dose is crazy, So this is a patient who is 76, okay, undergoing routine surgery. She is requiring 2.3% sevoflurane to keep her PSI at 39. Now, I wouldn't have thought a 70-year-old would require that much anesthesia. Whereas when I look at this 40-year-old, they're only requiring 1.6% sevoflurane, and they're pretty deeply anesthetized. So the idea that one size fits all doesn't work. You really have to measure it in every patient, and it's not difficult to do. This is something we forget, is that developmental brain doesn't behave like a normal brain. This is a paper published by Dr. Chun Bong from Singapore. Great paper. It goes through all the things that you see in children. And you can see the two children undergoing scoliosis. Same age, same weight, same sex. One with a global developmental delay, and the other patient is normal. And you can see that the child with neurodevelopmental delay is requiring half the dose of anesthesia as the child that have got a normal brain. And again, you wouldn't be able to see this if you didn't monitor it. And scoliosis surgery in a child is really long, blood loss, difficult. So really, the last thing you want is to be giving them too much anesthetic, more than they need, and then struggle with the blood pressure and struggle with the fluid management. And one thing that is clear to us in neurointensive care is that about 20% of our patients have got something called non-convulsive seizures. So they're not seizing, but they don't wake up. And when we do a full EEG on them, we find that they're having seizures. It's called non-convulsive seizures. The incidence in general intensive care approaches 10%. So 1 in 10 patients may not be waking up or maybe having seizures while they're being sedated in intensive care. And what we have done, again, with SedLine is you can pick up the seizures because you can see them as spikes here on this and a very high PSI number. And the next development in our SedLine will be automatic seizure detection. So you'll be getting seizures present or absent. You'll be getting the number of seizures per second. We're working on that at the moment, so hopefully it won't be too long before we have that information for you. So in summary about processed EEG, overdosing, not using the right dose, can only end up harming the patient. There is no benefit to having more doses than you need. There's no benefit to not knowing what you do. And if you compare general anesthesia with processed EEG to blind nasal intubations a few years ago, there used to be blind nasal intubations were all the rage when anesthesia started. Who would do that now? Who would do retrograde tracheal intubation when you have fiber optic scopes now? So really we move on, or we really need to move on in terms of what we do for anesthesia. Now that's the bit about giving the drugs. What about oxygenation? And oxygenation is really important because anything that disturbs the balance between what you're delivering to the brain and what the brain requires in terms of oxygen will cause injury, whether it's a reduction in perfusion, oxygen delivery because of low hemoglobin, anemia, diffusion, or anything that increases metabolism. So pyrexia, seizures, waking up, whatever. So you're always trying to balance metabolism to flow. And we are very good when we're normally coupled in the middle there. Again, I don't know why this sensor is not working. You can see that the blue line, the white line and the yellow line and red line are going up and going down in tandem. That's when the flow metabolism is coupled. When the flow metabolism is uncoupled, like it is on the left, more blood flow than you need for metabolism, you get hyperemia and swelling. And when the blood flow does not match up with the metabolism like you have on the right, you'll get ischemia and brain damage. And what we try and do is keep them in the middle. So this is the principle of NIRS and the way it works. What it does, it looks at oxygen delivery, looks at oxygen consumption, and works out a balance. So NIRS is not like pulse oximetry. We're not looking at the arterial signal. We're looking at the balance between what you've delivered, what the brain has consumed. So you need a little bit of time for the blood to go in, the brain to consume a bit of it, and then get it into the venous side. And that's why the averaging time is really important. Cerebral oximeters that work too fast measure the arterial signal rather than the true tissue brain signal. If you want to measure the arterial signal, use a pulse oximeter. But if you want to measure truly the brain saturation, you really need to wait a little bit. And you can measure brain saturations in many ways, not just NIRS. You can look at it through a jugular bulb catheter. You can use a PO2 probe. But the preferred method is NIRS. The reason is you're not going to be drilling holes in people's heads who are not having had traumatic brain injury or neurologic injury. And you're not going to be putting jugular bulb catheters in, eclamptic ladies or patients having liver transplants. So the reality is we would stick with NIRS. And the principle is quite simple. We shine a light from two emitters. They scatter around the brain and the subcutaneous tissue. We subtract the signals from each other by picking up through a shallow and deep detector. And then we come up with a percentage saturation based on that hemoglobin or tissue underneath that sensor is 70% venous and 30% arterial. And you come up with the saturation. And what's a normal saturation? If you look at how it works, when we superimpose it onto the flow metabolism thing, when the blood flow exceeds metabolism, it goes up, and it doesn't matter whether they're both going up or going down. When they're matched, it doesn't change. And when the blood flow doesn't keep up with metabolism, it drops. So what it tells you is a balance between what you're delivering and what you're consuming. It doesn't really tell you any more than that. What's a normal value? Very difficult to measure. So we look at normal populations. And generally speaking, if you look at this 32,000 observation, 98 volunteers, taking into account all sorts of things like gender, hemisphere, etc., roughly speaking, you should really aim for about 60% as a normal. And generally, most cardiac surgeons, cardiac intensivists, neurointensivists would look at a saturation of about 60%. If it drops below that, we intervene, or if it drops more than 5 to 10%. Some people are a bit more cavalier, wait till a 15% drop from baseline before they intervene. Our cerebral oximeter has been calibrated against a jugular bulb catheter, and it's got a 2% trend accuracy and 4% absolute accuracy. And really, in this kind of monitor, trend accuracy is much more important than absolute accuracy, because you want to see what happens when you do an intervention. So if I drive the blood pressure up, does it go up or go down, rather than whether it's 63 or 62? So it's really important to have a very good trend accuracy. Now, I told you about the saturation, that it tells you what's happening in terms of delivery and consumption, but it doesn't tell you why it's changing. Okay? So that's why we added the 3 new parameters: the change in oxygenated hemoglobin, deoxygenated hemoglobin, and total hemoglobin. So now the monitor will tell you what the saturation is, and if you zero it at baseline before you start your procedure, it will tell you the change in that saturation is based on an increase or decrease in oxygenated hemoglobin, an increase or decrease in deoxygenated hemoglobin, or a change in total hemoglobin volume. What's so good about that? Well, oxygen delivery can only come in with oxygenated blood, and consumption is reflected in the venous side. So when we look at this, you can look at the oxygen delivery by looking at changes in oxygenated hemoglobin. And you can look at the consumption, if you like, by the changes in the deoxygenated hemoglobin. So now you can really look at total blood volume changes in the brain, oxygen delivery in the brain, and oxygen consumption in the brain. And so you have a measure of total blood volume, you have a measure of what's increasing the oxygen delivery or decreasing it, and you have a measure of what's increasing the venous side or not. And so now the saturation that you see with all those parameters, the intervention would be appropriate to why it's changing. If the metabolism is going up, you increase sedation. If the oxygen delivery has gone down, you increase the blood pressure. If the oxygen deliveries come down because they're anemic, you might want to transfuse them. So that's how these parameters now can combine together. And again, does everyone that have a reduction in brain saturation do worse? No. But the evidence suggests that if you desaturate during cardiac surgery, orthopedic surgery, the more time you spend in lower saturation in intensive care, even during cardiac arrest, those who don't recover the ROSC after 5 minutes and normally have lower brain saturations. So some ambulances in Germany and in Italy have got cerebral oximeter as part of their cardiac arrest, out-of-hospital cardiac arrest protocols, and some of the ambulances in Albuquerque are doing a trial on 1,000 patients to do just the same. Now, we used it as part of looking at the way individual organs behave. So this is a study that we did, published in Critical Care Medicine, looking at patients when we're trying to improve their oxygenation during COVID. And what we tried to do was, do a recruitment maneuver, turn them prone, give them nitric oxide in order to improve systemic circulation. But we weren't looking at the brain at the time. So we looked at some of those, and we found that actually the recruitment maneuver may have improved systemic oxygenation, but it worsened brain oxygenation. And if I'm trying to improve oxygenation to get the vital organs better oxygenated, well, I'm doing the wrong thing. And the same thing actually with CO2 removal. That worsened brain oxygenation. But recruitment, but proning the patients and giving nitric oxide really improved oxygen delivery to the brain. And so we stopped doing recruitment. We stopped removing CO2. And we switched to proning patients regularly. And we gave them nitric oxide when we felt it was appropriate. We use bilateral cerebral oximeters for a reason, because we think that your oxygen delivery to your brain is dependent on two vessels coming in. And while most of us have got equal patent vessels, some of us haven't. There are elderly patients with narrowed stenosis on one side or the other. Surgeons quite often will turn their head quite abruptly to one side versus the other. They'll be in a different funny position. So this is an example of an eccentric aortic aneurysm repaired. And at the end of the procedure, everything was fine. Everybody was happy, except Amir Ahmed, who was the anesthetist, who said, I'm not happy because one side of the brain is 49% saturated, the other side is 74%. When they looked through the angiography, they found that they've obstructed the left carotid, and they pulled the stent back, and the patient had both sides oxygenated. You wouldn't be able to tell if you were monitoring both sides. Equally, this is a patient of mine that came in a few months ago, traumatic brain injury, aortic dissection. They've done the stenting, they sacrificed the left subclavian. The left carotid wasn't filling brilliantly, but it was adequate. Brought him back to intensive care, and you can see that the left side was reading 58%, the right side was reading 79%. Now, there were three options. We can take him back and try and improve that stent. The surgeon said, no way. We struggled enough as it was. We're not doing that. So wake them up and hope that the brain has got enough oxygen, or keep them asleep until the signals equalize. We kept them asleep for a little while longer, and the collateral circulation developed, and that was okay. We were able to extubate them a few days later. And the sensors fit in with your set line quite easily. All our traumatic brain injury patients come in, we stick the sensors on them, and we carry on as normal. We collect all the other data through our system. That's somebody who's adequately sedated, and that's somebody who's over-sedated. And our nurses can see this from the end of the bed and go, I think we cooked him a bit too much. Let's pull back on the sedation. If you combine the signals you get from, the information you get from SedLine and O3, you see here, if you just look at the O3 signal, it's dropping, no change in the total volume, but there's a reduction in the oxygenated hemoglobin and an increase in deoxygenated hemoglobin. So there's increased consumption in this patient. And when you look at the SedLine, you can see why, because the patient is waking up. So again, you can decide, I'm not ready for the end of the procedure here. You keep him back to sleep, or you say, right, let's just give him a little bit more oxygen. We'll pull the tube out. This is a really interesting case from Korea, which was sent to us a few months ago. A patient who came in for a liver transplant, had right-sided frontal lobe hematoma as well. And he had left-sided small vessel disease and narrowed distal ICA. And when they stuck the sensors on, they found that actually what was happening was the right side had burst suppression, unset line, and the brain saturation was high, 65%. But when you look at the parameters, both the oxygen delivery and the total hemoglobin was increased, but the total deoxygenated hemoglobin was low. So really, that side of the brain had oxygen delivery exceeding metabolic requirements, okay, because it was sick. However, the left side of the brain, which was normal, has a few artifacts, saturation is running at 47%. And if you look at that, the oxygen delivery was not meeting metabolic requirements. So you might all say, so what? Well, the so what is, how far do you drive the blood pressure to improve the normal side of the brain without increasing the hemorrhage on the side that's already got a hematoma in it? And if you don't have the ability to titrate slowly to get that better, you may overshoot. So what I said was, right, let's drive the blood pressure out slowly, give them some more blood because they're anemic at 7.7 grams per deciliter, and lo and behold, we got the saturation at about 55% without increasing the size of the hematoma. So it just gives you something that otherwise you wouldn't be able to do. And this is an example where burst suppression is not just a sign of over-anesthesia. Burst suppression is a sign that tells you the brain is not happy, okay? So when the brain's not happy, it goes into burst suppression. And this is an example of a patient with traumatic brain injury. You can see that when the brain tissue oxygenation drops up here, below 14, they go into burst suppression. You see black lines, blue tips. And when we push the oxygenation above 14 up to 2022, the burst suppression disappears. No change in the sedation. So when you see burst suppression, you need to think, is this over-sedation or is this a brain that's not happy? And that's why I think unilateral DSA is not really much use if you're dealing with sick people. You really ought to look at both sides of the brain. Because if they both have got burst suppression, you think you're giving too much anesthetic, you probably are. If one side has got burst suppression, the other side hasn't, then you need to think about why that is happening. And here's another example, again, from Dr. Bong, looking at an 8-year-old who's having a pacing wire put in. You can see there, when the blood pressure drops and goes into asystole, the patient goes into burst suppression. And when the circulation is restored, the patient comes out of burst suppression. So again, if you like, the brain is becoming a monitor of hemodynamics rather than the other way around. And many of the guys who are looking at these things now are saying, before you start worrying about hemodynamics, make sure the sedation or the anesthesia is right. Then you may need less volume of fluids, you may need less vasopressors, you may need less everything else that you worry about. So I want to finish off by talking about pressure autoregulation. I don't know, I'm sure you all know what cerebral pressure autoregulation is. It's maintaining constant brain blood flow and the mean arterial pressure is changing. And it used to be a thing that they did in neurointensive care and nowhere else. But now we're beginning to realize that autoregulation is really important. In sepsis, for example, Kate Rosenblatt and Hopkins has done a major project on that, showing that sepsis really affects your autoregulation and may be responsible for some of your brain injury that you see in sepsis. Post-cardiac arrest, what blood pressure is right for a patient post-cardiac arrest? Sometimes we don't really know, we guess. And now a lot of the studies that are driving this, for example, in Belfast, looking at autoregulation as opposed to a target blood pressure. Liver transplantation with hyperperfusion, and even high-risk obstetrics with eclampsia. And so what we do is we calculate autoregulation continuously in our intensive care unit. We have the ICP bolts, and we calculate autoregulation, and we display it here at the bottom using an ICM plus system, where it's green for present autoregulation, red it isn't. And we adjust the blood pressure to make sure the patient stays in the autoregulatory range most of the time. And it's very easy for us because people can see it from the end of the bed, change the blood pressure based on that. But we had to put ICP bolts for that. So we decided we'd look at NIRS and see if we can get similar signals. And lo and behold, we can. We can measure autoregulation non-invasively using NIRS. You can see here that the NIRS in the red and the PRX in green, they're not perfectly matched, but they do reflect the presence and absence of autoregulation. And this is something we are doing now on O3 sensors. It will be in the next few months where you'll be able to look at autoregulation without having to put in an invasive catheter or transcranial Doppler. I want to show you the effects of impaired autoregulation on outcome. This is a study looking at 134 patients undergoing cardiac surgery where they used cerebral oximetry to measure presence of absence of autoregulation and how far has the blood pressure strayed, if you like, outside the autoregulatory zone. And what was the average autoregulatory index. And then what they did is they assessed delirium using the CAM-defined delirium method and confusion assessment method for ICU. And this is a patient at the top with normal autoregulation. You see the lower limit, the higher limit, and how the oximetry changes. And the one on the bottom, you see that there's no change in the cerebral oximetry with changes in blood pressure, which means the patient is not really autoregulating. And the interesting thing is that those patients who had globally impaired autoregulation in the ICU had higher incidence delirium, almost 3 times as much. And those in the operating theatre, it's almost reached significance but didn't, but you can see there's a 12% difference. And when you look at the total time you were outside the autoregulated limit, again, highly significant in the operating room and almost significant in intensive care. So there's no doubt that straying outside the autoregulated limits really affects your ability to recover following major surgery or in intensive care. And this is the reason probably why. There's a patient after cardiac arrest, two patients. One patient's lower limit of autoregulation is 109, the other is 75. So where do you set the normal blood pressure in these people? You say it's 80, you say it's 90. Well, it won't affect the guy who's got lower limit of 109. And if you go 100, well, that's too high for somebody who's got lower limit of 75. And that's why individualized treatment is coming back into fashion. And this is really an interesting paper looking at autoregulation, comparing it to mean arterial pressure post-thrombectomies. I don't know if you do many strokes in many patients who post-thrombectomy here, but the biggest worry about it is the hyperperfusion syndrome after you remove the clot. So you remove the clot from an ischemic part of the brain has got very little ability to autoregulate, and you get hyperperfusion, you get swelling in that side of the hemisphere. And we can look at that bilaterally using bilateral O3. But what's interesting here is that it wasn't the blood pressure that seemed to affect the outcome in these patients, but whether they stayed or strayed outside the autoregulatory range. And this is why we really are interested in getting autoregulation into our O3 sensors so you can see it and use it on every patient that you get. Last but not least, I want to finish by looking at non-invasive cardiac output or minimally invasive cardiac output. You are familiar with LITCO. It's sitting here in front of me. It's a big clunky machine. So what we've done is we've switched that to a little device called the BIC. You plug it into any arterial line, plug it into the Root monitor that you already have to measure SedLine O3, and lo and behold, you get all the non-invasive cardiac output parameters that you normally see on the non-invasive cardiac output machine. Not only that, because you can measure hemoglobin continuously, and you've got cardiac output now, you've got saturation, we can work out oxygen delivery beat by beat. And so instead of looking at blood pressure, you're looking actually at oxygen delivery beat by beat on every patient with minimally invasive devices. So I can look at blood pressure, but it doesn't tell me how much oxygen is being delivered. I can look at saturation, it doesn't tell me how much oxygen is being delivered. If I look at DO2, I can tell what I'm delivering, which is what's ultimately important. And then when you look at DO2 and look at the end organ perfusion with the cerebral oximeter, for example, or somatic oximeter on the kidney or on the large part of your body, you can tell the consumption. So we can tell oxygen delivery, we can tell consumption. You've got the whole picture, non-invasively, in one display device. And the device doesn't have to be changed every time we upgrade it because all the technology is in the cable. So you take the cable out, give you a new cable, you plug it in, it works. So I think in the next couple of years, we're doing a big push on oxygen delivery. People are waking up. We used to have PA catheters, okay? You talk to intensive care guys, All the time they talk about stroke volume variation, volume responsiveness, blah, blah, blah. You go, how many patients do you measure it in? Only the very sick ones with PA catheters. Okay, what do you do for the other 80% of patients? Nothing. Does that remind you of brain function monitoring? Pretty much the same. So really what we're saying is that if you're sick enough to be in intensive care and have a PA catheter, you probably don't need non-invasive cardiac output. If you're sick in intensive care and don't have a PA catheter, shouldn't you have something else that looks at your cardiac output and oxygen delivery maybe? If you're sick enough to have major surgery, liver transplantation, major bowel resection, splenic resection, even revision hips with a limited cardiac output, don't you think those patients should have more than just blood pressure and heart rate measured? And this is non-invasive. If you put an arterial line in them, you can measure the cardiac output, you can measure oxygen delivery in them. So that's what we've been working on. Thank you very much for listening. I hope you're not too bored. I'm very happy to take some questions if you want them.